Okay. Can you hear me okay? Great. Yeah. So I get to talk to you about all the basics that you need to understand when you're thinking about this virus, the infections, and then how cancers develop. So HPV, or human papillomavirus, is just that. It is a virus that causes a little papilloma or a little wart and is a virus that can infect humans. There are other papillomaviruses. So there's cottontail rabbit papillomavirus, canine oral papillomavirus, bovine papillomavirus. So this virus has been around for the millennia. And of all the HPVs, we've noted to date more than 200 different human papillomaviruses, and they're defined based on different DNA sequences. And so when something has been identified and it's different enough, it's the next human papillomavirus that we have. So we have more than 200 that have been identified to date, and they just get the next number in sequence. So HPV-1 was the first one that was identified, and now we're past HPV-200. Human papillomaviruses are a DNA virus, so their genome, their information for how they need to work is made of DNA. They're really small. They only infect skin, so either cutaneous or mucosal tissue, so either the dry or more moist layers of our body. And they spend their whole life cycle in those tissues. So there's never a time that they should be in your blood system. There's never a time that it should be in your lymphatic system. They just infect, grow, and spread to the next place on someone's skin or mucosa, or to someone else's skin or mucosa. And HPVs, they're spread by skin-to-skin contact. They're not spread through your spit or through breathing or a cough or anything like that. It's really skin-to-skin. Those infections, for the most part, most people don't detect them at all. But when we think about HPV-associated cancers, there's a subset of HPV types that can lead to cancer. They do not, by definition, cause cancer 100% of the time, but for some cancers, they are fully required for the cancer to occur. So as Dr. Durm said, there are 6 different types of HPV-associated cancers that we think about. We're focusing on one of the 6 today, head and neck cancers. But the other HPV-associated cancers are cervical cancer, penile cancer, anal cancer, vulvar and vaginal cancers. In the United States, HPV-associated cancers are now the most common HPV-associated cancer that you can find. They've outstripped the rates of cervical cancers in the United States. This is not true for other countries, but in the United States it is. And so it's really important for us to be thinking about it. So I said that there are more than 200 HPV types, but only a subset of those cause cancer. The types that cause cancer are called high-risk HPV types. So low-risk HPV types cause either no clinical disease at all, but you can just find that virus if you search for it, or they may cause something that's like a little wart. But at the high-risk HPV types, of which there are about a dozen different types, those are associated with causing cancer in some people. And so when we think about high-risk HPV types, we think of them based on their number. And so HPV-16 is the most common high-risk HPV type. And that is the type that's found in the vast majority of HPV-associated cancers. When we think about how common these types of infections are, when we think about the types of HPV infections that can infect like the moist parts of our body, so head and neck cancers, those tissues are moist. The cervical cancers, again, mucosa. When we think about how common those infections are, they're extraordinarily common. So over someone's lifetime, before the HPV vaccine came out, 80 to 85% of men and women would have one of those mucosal HPV types of infections throughout their lifetime. So these are extremely common. And if you were to sample people in the United States, at least 75% of men and women would have evidence of a current or prior HPV infection that could be found in mucosal tissues. So with that, what we also know is not everyone gets an HPV-associated cancer. So some of those are low-risk infections of the mucosa, and so those don't cause cancer. And even some of us will have a high-risk HPV infection, but we don't necessarily get a cancer because our bodies are able to clear those infections. So although many of us will have had evidence of a current or prior high risk or low risk HPV infection, most of our bodies, if we have a typical immune system, can clear those infections. What we worry about clinically is someone who has a high risk HPV infection, so a type of HPV that's high risk for developing cancer, and our body doesn't clear that over time. So the length of someone's high risk HPV infection that is serially detectable over time is the greatest clinical risk factor for developing a cancer, like a cervical cancer or a head and neck cancer. When we look at people and think about ways that things are spread through skin-to-skin contact or sexually transmitted, most people after the first years after sexual debut, when we think about cervical cancer, most people have evidence of having an HPV infection and those clear. And so that really layers into one of the questions that we got, which is how we think about screening for cervical cancer. We know that people are able to clear these infections pretty well. And so we pay attention to HPV presence or absence in cervical smears as someone gets older, because again, we want these infections to be going away on their own. And so those are some of the things that we're also starting to think about when we think about HPV-associated head and neck cancers. How can we look at those same pieces of information for men and women who might be at risk of developing or having a recurrence of these cancers too? So HPV is very common. There are lots of different types. We really focus on the types of HPV that are associated with cancer. And we focus on, is your body able to clear those infections? And so it's a really important component when we think about those cancers, but it is not a 100% driver of cancers. So with that, Dr. Durm, I'll pass it over to you to talk a little bit more about head and neck.
Yeah, thanks so much. So today we wanted to just talk a little bit about how HPV relates to head and neck cancer. Together just a couple of slides here for that. There we go. So head and neck cancer, just as a general class, occurs in the mucosa, sort of the moist layers of the mouth, of the upper aerodigestive tract. And what that means is it can really occur anywhere along the tongue in the front, along the floor of the mouth, along the cheeks, in the back of the throat, up in the nasopharynx, and all the way down to your voice box. And really, we expect almost 60,000 cases of head and neck cancer in the US this year. And over 12,000 people will unfortunately succumb to this disease. Risk factors in general for head and neck cancer include things like tobacco use, both chewing tobacco and smoking, heavy alcohol use, and then as we've mentioned, and as the focus of today's talk, viruses such as HPV or EBV. HPV specifically causes cancer mainly in the oropharynx, a specific portion of the head and neck region. We can see HPV in other types of head and neck cancer, sort of in the front of the tongue, up in the nasopharynx, in the voice box, but to a very, very small extent. And only a couple % of patients with those particular types of cancer have HPV. And the sort of relationship between that and the treatment is less clear than it is in the oropharynx. But in the oropharynx, which includes your tonsils, the back part of your tongue where it connects to the back of your mouth, the upper roof of your mouth, and then the uvula, which is what hangs down in the back of your throat, are the most common places to find HPV-mediated head and neck cancers. And you can see a little graphic here on the right-hand side of all the sites you can get head and neck cancer, but most HPV-related cancers occur right here in this red circle. So epidemiology, the prevalence of oral HPV is estimated at about 7% of US adults. 4% of those having what we would classify as a high-risk type, as Dr. Katzenellenbogen already discussed. Highest incidence, at least in some studies, is in non-Hispanic Black adults, can be almost as high as 10%. The lowest is in Asian adults, roughly 3%. Caucasians often fall around 7 to 8%. It's higher prevalence in men, so males can have 3 to 4 times higher prevalence of HPV infections. In one study, at least, almost 12% of males versus about 3 to 4% for females. And then as has already been mentioned, most of these are actually cleared. You know, we are exposed to this virus and our immune system clears it. One of the types that has the lowest clearance rate is also one of the highest risk types, which is type 16, and that can persist in sort of your oral cavity or oropharynx for many years. In the US, 70 to 80%, and obviously this differs a little between studies, but roughly 70 to 80%, or nearly 3/4 of all oropharyngeal cancers, are attributable to HPV. And this has actually changed over the years, which we'll talk about in a moment. The latency period between being exposed, because most people are often exposed earlier in life, teens, 20s, and sort of don't know that they have that. But the latency period between contacting and hanging on to that virus and then developing cancer is often 10 to 30 years. And if you look at these graphs in the bottom, these are actually showing the same thing, just two different countries. The left is the US and the right is a European country. But what you see is the orange or yellowish bar is all rates of oropharyngeal cancer. And you can see that it's slowly increasing over time in the United States. But what's interesting to see is the blue and the green, right? The green are oropharyngeal cancers, which are not attributable to HPV. And you can see those are declining over time. And the blue is oropharyngeal cancers that are attributable to HPV. And that has gone from being sort of a minority of cases to being a large majority of the cases of oropharyngeal cancer in this country. And it's not just the US, you can see the same trend in Sweden on the right-hand side. So what's the pathogenesis? Dr. Katzenellenbogen knows this considerably better than I do, but I'll try to do it justice. HPV has two proteins, E6 and E7, has a number of others, but these are the most important in pathogenesis. So in these high-risk HPV infections, these can serve as oncogenes. Oncogenes is a term that just means a driver of cancer progression. And these work in a couple different ways. E6 degrades P53, and if you've ever heard of P53, it's because it's one of the most important preventers of cancer in the human body. And patients that are born with mutations in P53 get cancer very early in life. And many of the cancers, not just head and neck cancer, but many other types of cancers we will find have developed P53 mutations over time, which probably drives that cancer to grow. P53 is an important suppressor of cancer progression. E7 degrades a protein called RB, and through a complex series of steps, which we won't go through, but are sort of shown in the cartoon at the bottom. Basically, this drives cell cycle progression and increases the number of cells we make and ultimately leads to a cancer. So E6 sort of prevents the body from preventing or suppressing cancer formation, and E7 sort of drives that cell growth. So it's working in two separate ways to cause cancer in our patients. And this is a very busy table, but it really kind of shows that HPV negative and HPV positive head and neck cancers are almost two separate diseases, really. On the left-hand side, HPV negative, you can see the characteristics. On the right-hand side is HPV positive. So HPV negative, largely driven by exposures to alcohol and tobacco, whereas HPV positive disease, of course, is often driven by the HPV virus. And many of these patients have never smoked, used tobacco or alcohol in their lives. The subsites of where we see cancers are very different. For HPV negative, it's often in the voice box or larynx, or in the tongue, in the front part of the mouth, whereas it's mostly oropharyngeal for patients with HPV disease. The age of diagnosis is different. So patients that develop smoking and drinking related HPV negative head and neck cancers are often much older than our HPV positive patients who often develop the disease in their 40s and 50s. The way it looks under the microscope is different, but we won't get into that much. And I think most importantly on this slide, one thing to point out is that the response to treatments is considerably worse in patients that have HPV negative disease and considerably better in patients whose cancer is driven by HPV. And that leads to a difference in overall prognosis. So in terms of 5-year survival, which we oftentimes use as a surrogate for curing cancer, right? Overall survival at 5 years is about 50 to 55% if you have an HPV negative cancer, and it's 75 to 80% or sometimes higher in patients who have HPV positive cancers. And so that brings us a little into sort of how we treat these cancers and what we can do to use HPV to kind of change the way we look at these treatments. So this is a very generalized algorithm for treating head and neck cancer. The scope of this talk, the purpose isn't to teach you how to treat this. It's just to sort of give you a flavor of how we look at these patients when they come in. And they really, after their diagnosis, go down one of two paths. Either first they're sent to surgery where the tumor is removed, and then often the patients are treated with either some radiation or sometimes a combination of chemo and radiation just to prevent recurrence of that cancer. The other way they can be treated is non-surgically, where radiation is the basis for much of their treatment, and that can be given alone or sometimes in combination with chemo or even sometimes in combination with what we call a biologic medicine, like cetuximab, which blocks a different sort of protein and is technically not chemotherapy. So there are many ways we can do this. It's often a large discussion between multidisciplinary groups, including the surgeons, the radiation oncologists, and ourselves to try and figure out the best options for these patients. So this is one of the first studies that demonstrated to us that HPV positive patients do a lot better than their HPV negative cohorts. This is RTOG. RTOG stands for Radiation Therapy Oncology Group. It's a large academic group of centers that run clinical trials for our patients. And the study looked at two different types of radiation, not important to this particular slide. But the important thing, what I want you to take away from this is that the 3-year survival for HPV positive patients was 82%. And the 3-year survival for HPV negative patients was 57%, a 25% difference, simply because one group was HPV positive and one was negative. The hazard ratio was very low, so 62% relative reduction in death if you had HPV positive cancers. And there have been a number of other trials, and we won't show all of them for the sake of time, that have shown very, very, very similar outcomes in that this group of patients does remarkably better. So if they do better, how can we use that in our treatment algorithms, right? Well, one thing to remember is that while head and neck cancers are curable, the treatments are very difficult, right? Surgery is difficult, radiation is difficult, and these patients can oftentimes be left with long-term or late toxicities. And one study suggested that up to 43% of our patients treated with conventional or standard radiation treatments can have a severe late toxicity, and those can include things like speech deficits, swallowing issues, poor oral health, trismus, which is a difficulty opening your jaw to eat or drink or speak, and then chronic dry mouth. So the question is whether we can take these excellent outcomes in HPV positive patients and design strategies where we give less treatment or easier treatments to produce less of those late long-term severe toxicities, but get the same outcomes for our patients. And this is one of the first trials to look at this. Again, RTOG, different trial. And we won't get bogged down in the details, but basically the way we treat patients when they get chemo and radiation is with a very, very old drug called cisplatin. And cisplatin can have a lot of side effects, including nerve pains, kidney damage, nausea and vomiting, low blood counts, and difficulties with hearing, which can be permanent. And so the thought was, can we replace this toxic chemotherapy with a different drug called cetuximab, which when given alone is actually pretty easy to tolerate and often just causes things like rash or changes to electrolytes. And so this trial sought to compare the old standard of care radiation and cisplatin with this new radiation and cetuximab. And unfortunately, you can see here in the graphs on the right-hand side, the blue lines are cisplatin, the red lines are cetuximab. We saw improvements in progression-free survival with the old chemo drugs. We saw more recurrences with the use of cetuximab. And unfortunately, this trial showed that using an alternative drug was unfortunately inferior to our old standard of care. This is a separate trial, same exact design, but the endpoint was saying, well, does using cetuximab instead of cisplatin cause less severe toxicity? And we all expected that it would, but the reality was that it did not. The grade 3 to 5 toxicities are graded from 1 through 5, 1 being very, very minor, oftentimes 5 being death or severe impairment. So grade 3 to 5 toxicity is looking at the worst toxicities from these treatments. And cetuximab and cisplatin, along with radiation, had almost identical amounts of these side effects. And then again, when we looked at the outcomes for patients, did they live longer or the same with the alternative agent? The answer was no. Unfortunately, cisplatin was once again better than this alternative agent. And then just to hammer it home, a third trial looking at the same thing. This trial looked at both toxicity and outcomes, and once again showed that old chemotherapy still is superior to cetuximab. So despite multiple efforts to replace toxic drugs with newer and less toxic ones, we saw both that this did not decrease toxicity for our patients, and it actually led to inferior treatment outcomes. And so chemo and radiation has remained the standard of care for this group of patients. So if we can't change the drug around, what about giving less radiation? So this is a trial that took patients and put them into three groups. One is a very low risk group, and actually those patients just got surgery and then got nothing else. And were observed. And I will just tell you, though we'll see it in the next slide, those patients did very well with no additional treatment. And again, I should point out that all of the patients in this particular trial are HPV positive. There was another group which was high-risk patients, and they got standard of care. But the interesting part of this trial is right in the middle of this slide, is they took patients with sort of middle risk cancers, HPV positive cancers, gave them surgery, and then randomized them to one of two radiation doses: the standard, which is very high, or a lower dose, which we think will likely cause less long-term side effects. And what you can see here, the take home is there in the red circle, the patients did almost exactly the same despite getting less radiation, which is one of the first trials to suggest to us that perhaps we can start to de-escalate some of the treatments for these head and neck patients if they're HPV positive, get the same outcomes in terms of overall survival and recurrence rates, but not cause them those lasting side effects. And you can see the study arm A, 94% of patients did not recur even when they didn't get radiation. And in D, patients that got the standard of care did fairly well as well. So the conclusions here, HPV positive cancers carry a much better prognosis compared with HPV negative. We know that de-intensification strategies make a lot of sense to try and decrease the long-term toxicities for our patients. Switching chemo agents did not seem to be very beneficial, but the lowering of radiation doses does appear promising. So we're waiting for the final results of these trials and a number of other trials which are ongoing, looking at these strategies to treat our patients. And with that, I'm going to switch it back over to Dr. Katzenellenbogen to talk a little bit about prevention for HPV-related cancers.
So when I started working in this field, it was just before the HPV vaccine came out in a New England Journal article as being really highly effective in preventing infection and persistent infection. So I've had the pleasure of seeing this preventive way to avoid cancers come into the world. And it has been incredibly exciting. Even for someone who's fundamentally interested in the cellular biology of this virus and our host cells in driving infections and in driving cancers. So Dr. Durm pointed out some really important things when we think about low risk and high risk cancers. So as I said, HPV is a DNA virus. So its genetic makeup includes a small amount of DNA that informs how the virus can replicate itself. And there are genes in that DNA that are labeled E or L because they're expressed early or late in the viral life cycle. And in high-risk HPV types, the E6 and E7 genes are the drivers of cancer. Those genes in low-risk types are important for the normal virus life cycle, but when they're persistently expressed over time in a person, they can, in a high-risk infection, drive those cancers. HPV is really good at avoiding being detected in our bodies. So when we think about human papillomaviruses that cause just like a skin wart on our knee or on our toes or on our hands, if we're kids and we're playing on the monkey bars, you can see that you have a wart, but your body is not annoyed by it. It doesn't have any redness, any swelling, any tenderness. You see that with your eyes, but your immune system is not really figuring out that there's a virus there. Over time, your body gets rid of that virus. Over time, we know that most people's bodies get rid of low risk or high risk infections of HPV in our mucosal sites. But HPV is able to be kind of sneaky. And part of that is because the whole viral life cycle takes place in our epithelium, so in the mucosal or cutaneous layers of our body. This vaccine is different. It's different than if we were naturally infected with any type of HPV. And it's different for a couple reasons. One is it doesn't contain any DNA of HPV. None of those DNA genes that drive the virus or drive the cancers are included in the vaccine. It's actually only the protein shell of HPV. And in fact, it only includes one of the two main proteins that form the protein shell. Those are expressed late in the viral life cycle, and they're called L1 and L2. Again, L for late. L1 is the major capsid protein that forms the shell of the virus, and L2 is the minor. The L1 protein, you can make that in bacteria or yeast cells or in insect cells produce that protein, purify it, and let it just sit. And after about a day, that protein will self-assemble to look just like a virus. And so that's what our HPV vaccines are made of. They are made of the single protein that matches a single HPV type. And we take that protein with none of the HPV DNA in it. And rather than just putting it on our skin, right? That's how HPV infects different places in your body or different people's bodies. We take that protein and we use an injection and actually put it into a muscle. So then it finally can be well sampled by our body to create an immune response. And our bodies do an excellent job at mounting antibodies to these proteins when they're not in our skin, but actually going into a muscle. And so the data is profoundly supportive that HPV vaccines can protect us from getting an infection. They make better antibody responses than if we have a natural infection to these HPV types. They don't include any of the HPV DNA that can be cancer causing. And those antibodies appear to be really long-lived. So the current HPV vaccines that we have that are FDA approved in the United States protect us against 9 different types of HPVs. 2 of the low-risk HPV types that cause the vast majority, about 90% of genital warts. They also protect us against the same type of viruses that can cause recurrent respiratory papillomatosis in children, which is really important when we think about our airways and breathing. And then it also protects us against 7 different high-risk HPV types. And across those 7 types, it protects us from about 85% of high-risk types that cause cervical cancer and includes HPV 16 and 18, which are the vast majority of HPV-associated head and neck cancers. This vaccine is FDA approved in the United States down to the age of 9 and up to the age of 45 for all genders. If you are less than 15 and you start this vaccine series, you only need 2 shots. If you're 15 and older, you need 3. If you have an immune suppressed health status because you're on immunosuppressive medications or you've had a bone marrow transplant, you're HIV positive, you have an autoimmune disease, those would be people where you would need to get all 3 shots, even if you're younger than 15. And you would need to have a little bit more close monitoring for any types of infections in the future, just like with other infections. But the vaccine is extraordinarily effective. The vaccine was FDA approved in its initial sort of structuring in 2006 for girls and 2008 for boys. Then there's been the second round of the HPV vaccine that includes 9 different types. And so far, we really haven't found any evidence of consistent breakthrough infections over time, leading to someone maybe needing a booster shot to get their immune system boosted back up. But we have seen in clinical studies whether people would have a good antibody response if they did get a booster shot. It does appear to be really, really effective. I did talk about the fact that a lot of us have evidence of a current or prior HPV infection. And so these vaccines are extraordinarily effective in preventing an incidental infection or a persistent infection. And when we look at the lovely people who participated in these clinical trials, for how many of them might have had one of these 9 types of HPVs before they started the study, we saw that about half of those people had at least one of those infections starting. So it's just extraordinarily common for people to have an exposure and an infection with these types. And so it's really, really important for people to be vaccinated as early as they can and as effectively as they can. And that's the way that we can really be preventing cervical cancer, other anogenital cancers, and today, the focus on head and neck cancers. Most of the studies have been looking at the prevention of infections, primarily in women looking at cervical cancer, but have also looked at men and women when we look at genital warts, and have looked at men and women when we think about other types of anogenital cancers. There have also been studies looking at how well this vaccine would help protect men and women from having HPV infections or DNA that we can detect in the oral mucosa, and how well it might be able to protect people from getting those infections that might lead to cancers. And the vaccines do appear to be effective here, not just in the anogenital area. So it really does have a robust antibody protective response that can really help a lot of men and women in the future avoid getting cancers. Those are the main points that I wanted to make when we think about ways to protect ourselves from cancer. I think one of the things that Dr. Durm and I can also talk about is we have really clear guidelines for how to screen for cervical cancer that's HPV associated. We don't have very clear guidelines for how to screen for other HPV associated cancers, including head and neck cancers. We've done a lot of studies to look at how common can we find a low risk or a high risk HPV infection in the oral mucosa if we do gargles or swabs. How often can we see a lesion or feel a lesion? But we don't have great guidelines for, at this age, you should be screening this type of person. We just know that it's something that we want to be working on. And so there's a lot of research trying to identify ways to screen people that are effective. And there are also ways to be screening for people who maybe have had an HPV-associated head and neck cancer. And how can we try to identify if their cancers come back? So those are some things that are really important research. I think now Dr. Durm and I can maybe answer some questions that we've gotten. We've gotten a lot of questions that were sent ahead of time. Maybe Greg, I can read the questions and then you and I can decide who gets to answer.
Sure.
Does that sound good?
That sounds great.
So one of the first questions we have in thinking about the vaccine is that there are a lot of rumors about Gardasil. Gardasil is the brand name of the it was first a 4-valent, so 4 types, now at 9-valent, 9 types of HPV. When did those begin and how is research disproven? So I can talk about that a little bit. So I think there's been a lot of concern about vaccines and vaccine hesitancy, both in the US and other countries. I think it's not new to HPV to have people who are concerned about rumors, what might be going on. What we do know is hundreds of millions of doses have been given of the HPV vaccines in the United States and worldwide. And this vaccine is very, very effective and very, very safe. So I would say the research that's disproven it is both within the clinical studies that led to the FDA approval and tracking any adverse event that has happened for people who've been vaccinated and tracking that over time. And really, we have evidence in the millions and millions of people who've been vaccinated and have gained protection safely. So that's the first thing that I'll say. Okay. What are guidelines or the latest advancement in treatment options for head and neck cancers? Dr. Durm, that's for you.
Yeah, so I guess I'll talk to that in respect to HPV, right? Because I think the hottest topic in head and neck cancer treatment has really, or one of the hottest topics has been, can we treat patients with HPV positive cancer in a different way, right? In a less toxic way, in a way that doesn't impact their quality of life. Because we just talked about the fact that these patients get head and neck cancers oftentimes earlier than their HPV negative counterparts. They can be 40 or 50 treated patients in their 30s. And if we're treating them with therapies that are effective in getting rid of their cancer and they're going to live a normal life, you're talking about people that have 20, 30, 40 years of life left and have to live with some of the toxicity that comes with that treatment. And so, much of the research is sort of looking at ways to decrease long-term toxicity. I showed you some of those studies. Thus far, some of them have been a bit disappointing. I do think that we're starting to see some trials suggesting giving less radiation is helpful, or sometimes even leaving out radiation completely after a surgery is helpful. As of right now, it has not impacted the general clinical care we give these patients. If I see a patient in my clinic that's HPV positive and the patient right next to them has all the same clinical characteristics and is HPV negative, outside of a clinical trial, I treat those patients the same at this point. Sometimes that HPV positive discussion comes up in tumor board and in our multidisciplinary discussions, but for the most part, those patients really get the same care. But I highly suspect that's going to change probably in the next few years. If not the next few years, it's probably going to be the next 5 or 10 years that we start to see different paradigms of treatment for those different populations.
What would you say are the early warning signs that someone should be paying attention to when we're thinking about head and neck cancers or HPV-associated head and neck cancers?
Yeah, I think head and neck cancer in general, I mean, a lot of the symptoms are unfortunately kind of vague, right? Things that we experience all the time. A lot of us have sore throat, right? Or maybe some ear pain. These are things that, will last a few days. If you get a cold or you get some kind of viral illness, you may have symptoms that mimic the symptoms of head and neck cancer. But the difference is those should really only last for a short period of time. A few days and resolve, nothing probably to worry about. If the symptoms that you have of sore throat, or ear pain or jaw pain or neck pain are lasting for weeks and weeks on end, that's when you should be seeing your doctor to be evaluated. Other things which are not things to ignore, if you're feeling lumps or bumps in your neck, say you're shaving or washing your face and you notice a little bump under the skin, those are oftentimes lymph nodes. Those can be enlarged for benign reasons like viral illnesses and will usually go away after a week or two. If those are things that are enlarging in size or persistent for more than a week or two, then you should really be seeing your doctor for those types of things. If you're having difficulty swallowing, right, that's not really a typical symptom of an upper respiratory infection. If you're swallowing and your food feels like it's getting stuck in your throat, or you're unable to open your mouth the way that you used to, those are signs that you should be seen by your physician as well.
I'll answer one of these other questions, which is there any value in getting the HPV vaccine in someone who's had an HPV-associated oral cancer? And I'll actually broaden that out to all HPV-associated cancers. So there is the only range for like who qualifies or doesn't qualify for HPV vaccines right now is just age.
Mm-hmm.
So if you've had an abnormal pap smear or you've had an anal cancer or you've had a head and neck cancer, that's not a contraindication to be vaccinated. So there's no reason, there's no clinical indication. So there's no medical reason why you shouldn't be vaccinated. I would also argue that if you've had one high-risk HPV type, it's even more important to protect yourself from other types. Mm-hmm. In cervical cancer, with each additional high-risk HPV type that's detected in you either at the same time or sequentially over time, that puts you at greater risk of cervical cancer. Most head and neck cancers are just caused by one type, HPV-16. There are a few that are caused by HPV-18. But again, there's no harm in being vaccinated if you've had any of those 9 HPV types as an infection or with any sort of pre-clinical disease or pre-neoplastic lesion. And there are some clinical trials looking at whether receiving this vaccine after you've had a cancer will help decrease your risk of a new cancer development or a recurrence. There have been studies looking at this in anal cancer, and I believe there are studies of this also in head and neck cancer. When we think about head and neck cancer, Dr. Durm, you should correct me, but that it's interesting in that you can have a cancer and then you can have a new primary cancer that's not necessarily a metastasis or a recurrence. And so when I think about HPV as a researcher, I think about HPV infecting one spot, and then it can infect a new spot and a new spot. So it can sort of auto-inoculate in a person in addition to affecting another person. And so when I think about HPV-associated head and neck cancers, and if you've had one, there's no harm in being vaccinated to try to protect yourself from a future infection.
I completely agree. And I mean, I think we've got a question in this chat, which is kind of along the same lines. If you've had an HPV-related head and neck cancer, should you get vaccinated? And I think the answer is yes. I mean, the risk is exceptionally low. So if it doesn't end up benefiting you, there's really almost no harm to that. And if you're young enough that you're able to get that vaccine, then there's a chance it may help to slow or to prevent the development of another head and neck cancer or even one of these other types of cancer. So I would highly recommend getting those vaccines if you can.
And in looking at the low-risk types of HPV that are included in the vaccine, for people who've had a low-risk type infection and so actually have evidence of a genital wart, and yet they still receive the vaccine is still protected for them about 50% of the time. So that is, again, evidence of like avoiding auto-inoculation within your own body. So I think it's a good idea. There's a question, is there a test to detect head and neck cancers? And then perhaps maybe more broadly, is there a test to detect HPV?
Yeah, I mean, generally when patients have symptoms that are concerning, we do a couple things to sort of rule out a head and neck cancer. First is we send them to an ear, nose, and throat surgeon, who can oftentimes right there in the office take a camera, a small camera, and look down the back of their throat. And that's a pretty good screen to look for lesions that are worrisome for cancer, or even redness or irritation or ulcers that may point out that a cancer is present. The other thing we will do sometimes is a CT scan of the neck. Um, Neither of those two things really look for HPV specifically. They're mostly looking for signs of just cancer in general. To my knowledge, there is no clinical test to look just broadly for HPV in a patient that doesn't have a cancer diagnosis. As you mentioned, there are some experimental or research-based things where you can do mouthwashes looking for HPV. When patients get biopsies and we find cancer, we can test those for HPV. But for routine patients who stand in front of us that we don't know that have a diagnosis of cancer, I'm not unaware of any clinical way to test for HPV in those patients, at least for head and neck.
And HPV testing is starting to be rolled into cervical cancer screening. This has affected the way that women now are screened for cervical cancer. So there's a lot of sampling of not just looking for abnormal cells, but whether those cells have evidence of an HPV infection. So there already are clinical tests for HPVs, usually 16 and 18 or other high-risk types lumped together from that type of sampling. And so I would expect that pharmaceutical companies and clinical lab testings companies are really interested in understanding how that can be evaluated for people in real time for clinical studies, but it is not a part of normal screening right now. So,
Go ahead.
yeah, go ahead.
I think we're sort of getting close to the end, but a couple other questions I kind of wanted to ask. Maybe you would have any insight in this. Are there any changes to the sort of clinical guidelines for Pap smear screening for patients based on HPV status? Does it change for someone who's got high risk HPV versus someone who does not?
Yeah. So our clinical screening guidelines have really changed over the past 20 years because we understand the natural history of HPV infections and that link with a woman's age. So the younger you are, the better you are at clearing those infections. But if you're older and you have a persistent high-risk type, we start to get a little bit more conservative in how we're trying to track that over time. So our clinical screening guidelines for women now are based on your age and the presence or absence of HPV types. So if you're young and have an HPV infection, we actually try to not even look for HPV infections because we know so many people have them and you're going to clear them. But if you're older, sort of 24 to 30 and then 30 and beyond, including an HPV test within your sampling for cervical cancer screening on a Pap smear really helps drive how quickly you need to come back for a screen again for cervical cancer with a Pap smear, or want to be going for a biopsy of that tissue to look not just at the cells, but actually the structure of that tissue. And then if you have a normal Pap smear and you don't have an HPV that's detected either, that really allows women to spread out how often they're checked for cervical cancer, because we know, just as Dr. Durm talked about, it takes a long time to go from an infection to cancer. And so that affords us time in between sampling if things are looking healthy without any signs of infection. And we also know women over the age of 65, if they've been in a monogamous relationship and have had serial negative HPVs, at that point, you don't need Pap smears anymore. So this has really affected the way we screen women now.
There was a question I wanted to touch on. Someone asked if they're in a monogamous relationship a long period of time and had a head and neck cancer diagnosis that had been related to HPV. Do they need to change their sexual practices with their partner? And from what I saw in general, if you've already been with that person for 25 years, that exposure has probably occurred on a number of occasions. And if you've not gotten that virus at that point, your immune system is probably either adept at clearing or you've already probably been infected. So changing, I think, practices at that point would probably, I think the risk of developing it 25 years later would be very small. Would you agree?
Yeah, I would agree. I would agree. Those are things to be talking about on an individual basis with your doctor, thinking about your own health, your partner's health, your immune system status, things like that. But I think that typically people, when they're in a new partnership, that's when they have the biggest chance of an exposure.
Yeah.
So I think we're getting close to the end of time. And so we've gotten a lot of really great questions that have come in the chat and have come in before this session. If there are any other questions that people have, they're welcome to submit this now. But I think that this has been a really fun discussion and a really exciting time to be thinking about ways we can protect ourselves from infections and cancers.
Yeah.
Yeah.
Thanks so much for joining, everybody.
Thank you.
You /Simon Says. Thanks.